Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 58, that is the Haematuria and Anuria. In this lecture we will cover the causes of the Haematuria and Anuria, the lesions of the urinary tract, the Anuria causes, Haematuria causes, phase of oliguric. All these points are covered in these lectures. Let's start with the Haematuria. Haematuria is the common symptoms of the urinary disease. The most common cause of the Haematuria is the cystitis. As Haematuria is often the only symptoms of the various tumors affecting the urinary system, a thorough investigation should always be performed in case of the Haematuria to find out its cause. Inquiry must be made about its quantity and its relation to micturition. Haematuria may be microscopic in a few conditions, particularly ureteric stones. Haematuria may be profuse, as may be seen in enlarged prostate. When the blood appears at the beginning of the micturition, the cause is often in the urethra. When the haematuria occurs mostly towards the end of the micturition, the cause is mainly in the urinary bladder. When haematuria is initially mixed throughout the process of the urination, the cause is mainly in the kidney and ureter. This is the very significance to diagnose where is the blood coming from. A list of the various causes of the haematuria is given below. First is the causes. The various causes can be conveniently described under four headings. First is the lesions of the urinary tract. Second, diseases of the adjacent viscera involving the urinary tract. Third is the general disorders. And fourth is the after ingestion of the certain drugs. Dear students, here is the image on your screen. You can see the haematuria, the blood is collected in the bottle. You can see how it looks like. Now, the first cause is the lesion of the urinary tract. From the kidney, congenital polycystic kidney, traumatic ruptured kidney, that is the important cause, inflammatory tuberculosis, important cause, and acute pyelonephritis, neoplastic adenocarcinoma of the kidney, important cause, nephroblastoma of the kidney, papilloma of the renal pelvis and angioma, and other causes are the stone, infarction, and the essential haematuria. And the second in the lesion of the urinary tract is the ureter, the papilloma important cause and stones. Third is the bladder, traumatic rupture, inflammatory cystitis, very common cause, tuberculosis and bilharziasis, neoplastic papilloma and carcinoma, very common cause, and others are the stones. Fourth is the prostate, benign hypertrophy of the prostate, very common cause and carcinoma of the prostate. Fifth is the urethra, traumatic rupture, inflammatory acute urethritis, neoplastic transitional cell carcinoma, and others are the stones. Now the second cause of the haematuria, that is the disease of the adjacent viscera, acute appendicitis, salpingitis, and pelvic abscess. The inflammatory process may spread to the ureter and the bladder. Carcinoma of the rectum and the cervix ureteri may infiltrate the bladder to cause the haematuria also. Now the C, general disorders, blood disorders, purpura, sickle cell anemia, hemophilia, scurvy, and malaria, infarction, arterial emboli from myocardial infarct and subacute bacterial endocarditis. Third is the congestion, right heart failure, and renal vein thrombosis. And fourth is the collagen diseases. And the fourth and the final reason cause for the haematuria, that is the drugs, anticoagulant drugs like hexamine, sulfonamides, and salicylates when given in large doses. Now the next point is the anuria. Anuria means the absence of the excretion of the urine from the kidneys for minimum 12 hours. There is another term called oliguria, which means the excretion of less than the 300 ml of urine in 24 hours a day. Anuria may occur due to the various causes which can be conveniently described under the three headings, that is the pre-renal causes, renal causes, and the post-renal causes. That is the first we will see the pre-renal causes. Normally the systolic blood pressure in the glomeruli is about 90 to 100 mm of Hg. When this blood pressure falls below the up to the 70 mm, infiltration from the glomerular ceases. So any causes which lower the blood pressure may cause anuria. These causes are severe hemorrhage, shock, extensive burns, dehydration from vomiting or diarrhea or excessive sweatings, spinal anesthesia which lower the blood pressure, and cardiac failure. Treatment is directed to raise the blood pressure by administering intravenous dextrosaline solution. In case of the hemorrhage, blood transfusion is required. It will be seen that when the blood pressure is raised to a normal level urine excretion is also started. It must be remembered that the treatment should be immediate, as hypotension for a longer period may cause damage of the renal epithelium, glomerular damage, and even tubular necrosis to pass the condition to one of the renal anuria. Now the second is the renal anuria. This is mostly due to the damage or ischemia of the glomeruli and of the renal tubular epithelium. The main causes are incompatible blood transfusion, crush syndrome, severe shock for long period more than 2 hours, bilateral pyelonephritis, concealed accident hemorrhage and abortion, acute pancreatitis, bacteremic shock, operation of jaundice patient, certain drugs with cephalosporins and aminoglycosides, certain poisons, toxins of eclampsia, contrast media for aortography, chemicals, mercury salts, carbon, tetrachloride, etc. Renal anuria can be reversible and then it goes through 3 phases: phase of the oliguria, phase of the diuresis and phase of the recovery. Now the clinical features: patient passes dark urine of a constant specific gravity of 1.010 or is found on catheterization. The patient becomes anorexia with hiccup. Gradually the patient starts vomiting, which becomes copious and effortless. These are the symptoms. Now the treatment: diagnosis must be established first and post-renal or obstructive anuria must be eliminated by radiography or an ultrasound. In case of the incompatible blood transfusion, the blood transfusion should be immediately stopped and diuresis is provoked with mannitol or 500 ml of Rio macrodex given intravenously. The most important fact in the management of the renal anuria is to restrict introduction of fluid. Most of the deaths in this condition have been caused not by the urea or end products of the nitrogen metabolism but due to the excessive of water and electrolytes, particularly potassium. The treatment is conveniently described according to phase of the renal anuria. Now first the phase of the oliguria. Here is the intake of water. Water should be given considering the loss of the water which has occurred in the last 24 hours. Second is the electrolyte balance. It must be remembered that the sodium chloride and the bicarbonate or lactate should never be infused in this condition. Similarly, the fluid containing potassium should be prohibited, as rise in the serum potassium is the greatest threat to the patient's life in this condition. If serum potassium is seen to be the above normal level, calcium resonin enema is a simple method to exclude the potassium. Whenever intravenous fluid is required, it should be given by 5% dextrose solution. A little amount of the insulin may be added to this solution to lower serum potassium level. This method may be applied primarily in case of the raised serum potassium level. Now third is the diet. Diet should be free of protein and rich in carbohydrate. Approximately 2000 calories are required per day. Fourth is the antibiotics. These patients are prone to be involved by the various infections, so antibiotic is necessary. And the next point is the proper nursing care. Proper intake and output chart should be maintained. Blood pressure, pulse rate and respiratory rate should be noted every 4 hourly. ECG monitoring. Now next point is the dialysis. When the urea and the potassium levels are rise dangerously in the blood and is associated with significant uremic distress symptoms, that is the vomiting, muscular twitching and altered states of the consciousness, there is no way out but to perform dialysis to remove the waste products from the blood. One of the two methods is usually adopted. First is the peritoneal dialysis and second is the hemodialysis. First is the peritoneal dialysis. Peritoneal dialysis can be performed under local anesthesia by insertion of the fenestrated catheter into the peritoneal cavity. The catheter is introduced just inferior to the umbilicus in the midline. Sterile dialysis fluid is injected into the peritoneal cavity through the catheter. After a variable time, the fluid is drained into the closed drainage system. The process is repeated in cycles. The main disadvantage of this peritoneal dialysis is the potential of introducing infection into the peritoneum. It is rather slow in correcting metabolic imbalance. Recent abdominal surgery is a contraindication to the peritoneal dialysis. For the peritoneal dialysis. Second is the hemodialysis. A double lumen catheter is introduced over a guide wire into one of the great veins, that is the jugular subclavian or femoral. Dialysis fluid is introduced through the catheter. A few sessions of the hemodialysis is an effective life-saving measure. Between sessions of the dialysis, heparin solution is used to keep the lines patent. The main advantages of hemodialysis is that the metabolic abnormalities are corrected rapidly. The disadvantage is that the heparinization is necessary after the hemodialysis. Hemofiltration. This is the particularly required for actually ill patients It is almost like hemodialysis, which is performed outside the body with the help of an extracorporeal machine. The advantage is that the appropriate concentration of the various ingredients, that is the glucose, sodium, calcium, magnesium, chloride and the lactate, can be added in the plasma as may be required. Second is the phase of the diuresis. When diuresis starts, the input should be equal to the output of the urine in the previous 24 hours plus daily invisible losses. Usually this phase does not begin before 7 days of the allegoric phase. This is the time taken for the epithelium of the lower nephrons to regenerate sufficiently to prevent reabsorption of glomerular filtrate. So urine starts passing in this stage, there is often greater loss of the sodium and potassium. So this should replace when the amount of the urine reaches are 1 liter per day, then only blood urea starts falling. Third is the post-renal anuria. This is usually due to the obstruction to the flow of the urine through the lower urinary tract. This is mostly due to the renal stone obstructing the urinary tract, and hence it is often called calculous or obstructive anuria. Other causes of the post-renal anuria are malignancy. Now the clinical features. Usually males are affected between the ages of 40 to 60 years. Gradually complaints of headache, sleeplessness, that is the insomnia, and lassitude as the blood urea gradually rises. Later on uremia develops kidney in usually functionless due to hydronephrosis or pyonephrosis. Management. First, a catheter has to be passed to exclude the retention. That means no urine will come out through the catheter except a very small amount of the blood stained urine. Second is the straight X-ray of the QB region is taken to detect the obstructing stone. Ultrasound is not helpful to detect the stone but may demonstrate dilated pelvis and calyces. Third is the next, a cystoscopy is done and catheterization of both of the ureters is performed. 1 ml of liquid paraffin is injected through the catheter and then the catheter is removed in an attempt to expel the stone spontaneously. If catheterization does not help to remove the stone, ureterolithotomy should be performed, or if the stone is impacted at the ureteric orifice, meatotomy may be performed to extract the stone. If the stone is impacted in the lower 1/3 of the ureter, a Darmia basket may be used to extract the stone. And fourth point of the management of the anuria is the percutaneous nephrostomy. The collecting system of the obstructed kidney is punctured under the ultrasonic control. A guide wire is passed down the needle. A few small dilators are passed till the special nephrostomy tube can be inserted in the renal calyx. This provides drainage of the urine or pus without removing the definite stone. Fifth point is when no stone is detected in X-ray and catheterizing, cystoscopy or percutaneous nephrostomy could not relieve the obstruction. The kidney should be explored. Pylostomy or nephrostomy may be necessary. Next point is insertion of a stent. Nowadays, open J stent is inserted to drain the ureter into the bladder. Dear students, here is the end of our surgery lecture number 58, that is the hematuria and anuria. Thank you.